So, sir, it's 3, 2, 1. We are live to the audience platform. Over to you, Gajanan, sir.
Hello everyone and very good evening to all of you. I am Dr. Gajanan Panchal, Medical Advisor, Lupin Limited, and I extend very warm welcome to all of you in today's Gut Connect CME program. It's our privilege to have such an esteemed group of healthcare professionals who share commitment to advancing patient care through continuous learning. The Gut Connect webinar series is the first interface webinar for physicians and specialists in gastroenterology dedicated to advancing knowledge and management of functional dyspepsia with special focus on postprandial distress syndrome. Gut Connect has been organized by Lupin, and Lupin as an organization has a strong presence in the field of gastroenterology over decades. And we pioneer in creating scientific programs and initiatives to disseminate knowledge across spectrum of gastrointestinal diseases. Today, we are proud to announce our speakers from renowned Gastroenterology Institute, AGI, the Gastro City, Ludhiana. It's our honor to have Dr. Nirmaljit Singh Malli as the chairperson for today's event. Dr. Nirmaljit Singh Malli is the chairman and chief of gastroenterology at AGI, Gastro City, Ludhiana. He has more than 2 decades of experience. Dr. Malli has been instrumental in bringing cutting-edge techniques such as POEM, third space endoscopy, cholangioscopy, and advanced therapeutic endoscopy to North India. He has delivered over 200 lectures at various national and international forums and authored multiple publications. He is the founder, secretary of Punjab chapter of IHG. Dr. Malli is known for his leadership and vision. Dr. Malli continues to mentor the next generation and shape the progress of gastroenterology in the region. Welcome on board, Dr. Malli.
Thank you. Thank you so very much.
We are honored to have Dr. Neeraj Singla as the speaker for today's event. Dr. Neeraj Singla is a dedicated gastroenterologist currently with AGI, the Gastro City, Ludhiana. He is a postgraduate in medicine from DMC, Ludhiana, and received super specialist degree in gastroenterology from Osmania Medical College, Hyderabad. Dr. Singla has been trained at leading institutions including AIG Hospitals, Hyderabad, and Fortis, Ludhiana. His areas of expertise include GRD, motility disorders, NASH, and pancreaticobiliary diseases. He has several publications at national and international forums, and several book chapters has been authored by him. Dr. Singla is widely recognized as a young thought leader contributing to the advancement of reflux and functional GI disorder management. Welcome on board, Dr. Singla.
Thank you so much.
We have Dr. Rajiv Grover. We are privileged to have him as the speaker for today's event. Dr. Rajiv Grover is the vice chairman at AGI, the Gastro City, Ludhiana. He has more than 18 years of rich experience in the field of gastroenterology and hepatology. Dr. Grover has made his mark as an expert in advanced endoscopy interventions, therapeutic endoscopic ultrasound, and spyglass cholangioscopy. He is DM in gastroenterology from prestigious GB Pant Hospital, New Delhi. He has delivered lectures and shared his expertise at several national platforms. Dr. Grover continues to be leading voice in promoting innovations in endoscopy and patient-centered gastroenterology practice. Welcome on board, Dr. Grover.
Thank you, Dr. Gajanan, for the kind introduction. Thank you.
So now, without wasting much of time, I will hand over the session to our chairperson, Dr. Malli, to conduct it further. Over to you, sir.
At the outset, a warm welcome to all the people who are connected to this webinar. And I'd like to thank Lupin Pharma for taking this wonderful academic initiative of bringing people together, where the specialists in a given area, they can share their experiences and the academic content with the practicing physicians. It's a privilege for myself and my team, AGI The Gastrocity. I'd just like to brief about that AGI is now approximately a 5.5 years old institute. It's a group of very competent professionals, 4 gastroenterologists, Dr. Rajiv and Neeraj being 2 of them, who are being there in this platform today, 2 GI surgeons, and very competent backup with intensivists who are specialized in GI intensive care, anesthesiologists, GI pathologists, and radiologists. So already in 5.5 years, we have made a big mark in this whole region, not only in Punjab, but even I would say the surrounding states from J&K all the way to Delhi. And the team is so adept in academic activities that we have already been very active in different arenas. And when actually Lupin approached, we were actually more than willing to be part of this academic activity. So today, the topic which has been chosen is something really of great interest to the practicing physicians, and which is for few reasons. One, this is something we come across so commonly in our day-to-day practice, that is functional dyspepsia. 2, there are so many gray zones in both the diagnosis and in the management of functional dyspepsia, with the latest Rome 4 criteria subcategorizing into 2 distinct subtypes, one being called the EPS, another is called the postprandial distress or the PDS, which my colleagues will allude to in great detail in both the presentations. And then I think we'll be looking at the treatment options in a case-based fashion. So different cases where there could be certain overlap of one with the other and how to manage them appropriately. So with these words and what I think as introduction has already been given by Dr. Gajanan, I can tell both the speakers, both my colleagues, Rajiv being a senior colleague and Neeraj again the younger one, but very, very competent, very dynamic colleagues, both of them, good command over the language and the subject. So what we are going to have in the next, I believe, 50 or 55 minutes from now, we are going to have a great academic feast where Dr. Neeraj Singla in a case-based fashion will take us through the pathophysiology and the clinical diagnosis part. And Dr. Rajiv later will take us through the treatment landscape with a special emphasis in the end on the role of ecoshiamide, which is a very specific drug for PDS, and it's a wonderful drug. And I think all of us will become wiser once we reach to the conclusion of this webinar. And question and answers will take once both the presentations are over. And with this, I invite Dr. Neeraj Singla with his presentation. Thank you.
Thank you, sir. First of all, a very good evening to everyone. I would like to thank Lupin, the whole team, for inviting me for this webinar, making me part of this. So I will be discussing about functional dyspepsia. We'll be discussing about 3 cases, but before that, so I will be discussing the pathophysiology of functional dyspepsia and with a special emphasis on early satiety and postprandial syndrome. So if we take dyspepsia broadly, so when we see the population distribution, 20 to 30% of patients with dyspepsia, they have some organic cause to their dyspepsia. So rest of the 70% patients, they don't have any organic cause. So they likely have a functional dyspepsia. So which we are going to focus today, this 70% group, which don't have any organic or any cause to the dyspepsia. So if we talk about the organic causes for the dyspepsia, so these can be peptic ulcer disease, there can be any gastric or esophageal cancer, so there can be gallstones, chronic pancreatitis, pancreatic cancer. So even patients with celiac disease or lactose intolerance, they can present with symptoms of dyspepsia. But we are going to discuss the functional dyspepsia group, so which is a major chunk in our routine practice. So they have neither a structural disease or any biochemical explanation for the symptoms. So coming to this group of functional dyspepsia patients, so the global prevalence ranges from 20 to 30%. So in a physician's routine practice, so there in the routine OPD, 20 to 40% patients present with functional dyspepsia. So why this wide variation? So this can be attributed to different diagnostic criteria used to diagnose functional dyspepsia and different geographical regions. So now coming to the symptoms. So how do these patients present to us in the OPD? So usually they come with either, as Sir has discussed, that they can be epigastric pain syndrome, so which include epigastric pain or discomfort, or there can be a second subgroup, which is a postprandial fullness as well as early satiety. So they can also have bloating sensation. Belching usually is part of gastroesophageal reflux, but these patients again can have this thing. Along with that, some patients can have nausea, vomiting, and they can have a weight loss. Probably they try to reduce their diet to reduce the symptoms, so that can lead to weight loss also. So coming to this Rome 4 criteria, so which defines functional dyspepsia. So there should be a presence of one or more of the following symptoms. So if the patient has bothersome postprandial fullness or bothersome early satiety, so this group combines to form the postprandial distress syndrome. On the other hand, if the patient has epigastric pain or epigastric burning, so this forms our epigastric pain syndrome. So patient can have either epigastric pain or they can have postprandial distress, but some patient can have an overlap of both of these. So the endoscopy should be classically, it should be normal. There shouldn't be any structural disease on endoscopy. The symptoms should be present from the last 3 months, and the onset should be at least 6 months before the diagnosis. So very important. So there are various dietary and lifestyle factors which can precipitate functional dyspepsia. So coming to the lifestyle factors, there can be associated stress, anxiety, which can aggravate dyspepsia. There is definitive role of smoking, any excessive tea, coffee intake, alcohol, overweight, obesity, or high performance exercise like HIIT, or they can precipitate dyspepsia. There are specific food items also, excessive fatty food, oily fried items, hot spicy foods, carbohydrate rich foods, or high fiber foods can also trigger the symptoms. So coming to some meal related factors, if the energy intake in single go, the meal size is like large, so that can also precipitate the symptoms. That's why we recommend the patients to take small meals, probably at a frequent intervals. The dietary composition again is very important. So if it is a high carbohydrate or high fat diet, so that can also contribute to the symptoms. So all these factors lead to visceral hypersensitivity, gastric dysmotility, which I am going to discuss in the further slides, leading to a meal-related functional dyspeptic symptoms. So if we see the broad pathophysiology, so there is some contribution by the CNS because of anxiety, stress, and there can be due to the hydrochloric, due to the acid or wall distension, there is a peripheral as well as central hypersensitivity of the nerves. So there can be contributing gastroesophageal reflux by the gastric acid or bile acids, and there can be inflammation usually caused by H. pylori. So H. pylori is an important contributing factor to dyspepsia. We're going to discuss in the further slides. There can be associated duodenal inflammation by again the gastric acid or bacteria or viruses. So all these factors lead to either a decreased fundic accommodation, abnormal distribution of gastric contents, delayed gastric emptying, over distended antrum, leading to dyspeptic symptoms. So if we see how a normal individual differs from a patient who has symptoms of dyspepsia. So whenever somebody takes a meal, so what happens is there is a relaxation of the fundus so that there can be accumulation of food in the fundus part. So if this relaxation is not there, so this patient will start having symptoms of early satiety. So immediately after taking a meal, they will start feeling fullness of the abdomen. So second thing which happens is the mixing of food in the corpus. So there should be proper contractions. So like we talk about cardiac patient, they have tachycardia or bradycardia. So similarly in patient with dyspepsia, there can be either tachygastria or bradygastria. So the rhythm is either inadequate or it is too fast. So which can again lead to symptoms of dyspepsia. So third component is there is a proper coordination of the antropyloric region. So there is contractions of the antrum and there is a relaxation of the pylorus region followed by a relaxation of the duodenum. So in patients with dyspepsia, what happens is either there is a poor antral contraction or there is a functional contraction of the pylorus. So there is no mechanical obstruction. The pylorus is not providing way to the upcoming food bolus. So or there is a resistance by the duodenum. So all these factors lead to accumulation of food in the stomach for a longer period or leading to the symptoms of postprandial distress, bloating sensation, nausea and vomiting sensation. So now coming to the approach to diagnosis and treatment. So if you have a patient who comes to your OPD with symptoms of dyspepsia, either EPS type, PDS type, or an overlap of that. So first thing which you have to look is whether your patient is more than 50 years of age or he is having any alarm symptoms. So what are the alarm symptoms which you should be looking for? So it could be either your patient, if your patient has dysphagia, your patient is having recurrent vomiting, your patient is having a significant weight loss, there is a GI bleed, or your patient has a family history of gastric cancer. So if any of this risk factor is there, you should directly refer this patient for an upper GI endoscopy. On the other hand, if your patient is less than 50 years of age, there are no alarm symptoms. So then we can broadly categorize these patients into 3 groups. So if your patient also has a GRD symptoms, so GRD symptoms include like classical symptoms are heartburn or regurgitation. Then you can empirically put these patients on PPI. So if there is a good response, treat as GRD. So if there is no good response, then we'll discuss further. Second group is patients who are on NSAIDs, probably due to osteoarthritis or due to any backache or any migraine, so or any other probable offending medication. So you should try to either stop these medications or try to switch these medication to a safer medications. So third group is patients who are neither on any offending medication and they don't have any symptoms of GRD. So in a high prevalence region like India, we are a high prevalence region. So we should opt for a test and treat strategy for H. pylori. So what is test and treat strategy? So I'm going to discuss in the upcoming slides. So if the test and treat for H. pylori is positive, we should treat for H. pylori. If it is negative and your patient is not responding, again, we should do an endoscopy to look for the causes of dyspepsia. So very important slide. So what is the role of endoscopy when we should consider doing an endoscopy? So how does it help in patients with dyspepsia? So normally what happens is we usually do an endoscopy with a 6 to 8 hours fasting. So if we find that the stomach is still full of food, there's residual food in the stomach. So that gives us a good hint that this patient might be having gastroparesis. So again, next we can diagnose gastric cancers. We can diagnose presence of any erosions or ulcers. And another important aspect is diagnosing of H. pylori. So we can visually see the features of H. pylori gastritis. There can be erosions, there can be nodular gastritis. Along with that, we can confirm using a rapid urease test as well as histopathology. I'm going to discuss that. So now coming to the test and treat strategy for H. pylori. So it can be broadly divided into either a non-invasive method or it can be invasive methods for H. pylori. So the non-invasive methods include the urease breath test. So it is not easily available. Otherwise, it's a good test to do. So second test is the stool antigen test. So it is available and usually the best recommended test for a non-invasive method of H. pylori. Serology, again, not recommended because it cannot differentiate between present and past infection. So among the invasive methods, as I discussed, that we can just visually see the gastric body and antrum to diagnose H. pylori. Along with that, we can take a tissue specimen. We can use rapid urease kits. We put the tissue specimen on the rapid urease kit. And if the color changes from yellow to pink because of the release of urease enzyme, so we can confirm a diagnosis of H. pylori. So this we can immediately diagnose like within 15 to 20 minutes. So next, what we can do is we can send the same tissue specimen and we can send for histology or culture, which is again a very good method to confirm presence of H. pylori. PCR tests usually not recommended for routine practice. They are mainly used for research purposes. So briefly about gastric emptying study, if you are suspecting that your patient is having gastroparesis, there is a definitive role of nuclear scintigraphy. So in this test, we give food which is radio labeled, either a solid food or a liquid food. So we see how much time it is taking to empty at 1 hour, 2 hour, and at an interval of 4 hours. So the normal time taken for a solid meal, it is usually 90% of it empties within 2 hours, while there is complete emptying by 4 hours. While for a liquid food, majority gets emptied within 1 hour, and within 2 hours, the majority of liquid food gets emptied. So if there is the time taken is more than that, we can label these patients as having gastroparesis. So briefly about electrogastrography. So similar to like what we are doing for cardiac patients, ECG. So this is how an ECG machine looks like. So similar to ECG electrodes, we place 3 electrodes on the abdomen. So this helps us differentiating those patients who are having a functional pylorospasm. So there is no mechanical obstruction. So this pylorus doesn't allow the food bolus to go into the small intestine. So this group of patients respond very poorly to prokinetics, and there is a definitive role of balloon dilatation, or there is a new procedure called G-POEM, by which we can cut the muscles of the pylorus using just an endoscope. So with this background information, so I am going to discuss 3 cases with presentations of dyspepsia. They are having some different kind of presentation. So my first case is a 57-year-old female who is school teacher. The symptoms of bloating, discomfort, epigastric pain, nausea and vomiting, early satiety and anorexia. Now you can see there are both symptoms of EPS as well as PDS. The symptoms are there from last 1 year and they have worsened from last 2 months. There is history of 6 kg weight loss. Physical examination, BMI is normal. The vitals were normal. There is slight tenderness in the epigastric region. Hemoglobin slightly reduced, but the ultrasound abdomen, which is again a very important investigation, it should be done in routinely in all patients, was normal. So the differentials for this patients could be either a peptic ulcer disease or it could be a functional dyspepsia. So we went ahead with endoscopy in this patient. So it showed severe gastritis. You can see red spots distributed in the body and the antrum region, and took a biopsy from there. And we did a rapid urease test using this RUT kits. So this is how a normal kit looks like. This is a well area where we place the tissue specimen. So if the color changes from yellow to pink, so within 15 to 20 minutes, we can confirm our diagnosis of an H. pylori. So in our case, the H. pylori test came positive. So final diagnosis of functional dyspepsia with an overlap of both EPS and PDS type with non-atrophic gastritis due to H. pylori infection was made. So the treatment part will be discussed by Rajiv sir. So I will move on to the second case. So second case is a 35-year-old male who is a driver by profession. Again, there you can see there is postprandial fullness as well as epigastric pain. So both an overlap of EPS and PDS. Early satiety from 4 months. So now this patient also has a heartburn and belching, so which are usually seen in GERD. So patient was treated with PPIs as expected, esomeprazole, rabeprazole, omeprazole, various types of PPI tried, but there was poor response to treatment. Vitals were normal, ultrasound was again done, it was normal. So this is what the endoscopy looked like. Though there was no evidence of esophagitis, no ulcers, no erosions, but there was definitive evidence of a lax lower esophageal sphincter. So by Hill's grade, it was a 2nd grade. So probably indicating there might be some reflux, or this patient might be having a non-erosive reflux disease. So final diagnosis of functional dyspepsia with a GERD overlap was made in this patient. So coming to my last case, So this is a 42-year-old female, manager, sedentary lifestyle, 6-month history of intermittent postprandial bloating, fullness, early satiety. Now you can see this patient only has the symptoms of postprandial distress. There is no epigastric pain or discomfort, but this patient suffered from anxiety, lack of sleep, panic attacks, and she was prescribed PPIs, but the treatment was not successful in completely alleviating her symptoms. BMI slightly raised, vitals were normal, and endoscopy done in this patient was absolutely normal. There was no gastric or duodenal ulcers, no gastritis, and the RUT was negative for H. pylori. So final diagnosis of functional dyspepsia, which is a PDS type with an overlap of generalized anxiety disorder, was made in this patient. So with this, I end my slides and I hand over to Dr. Rajiv to discuss the management part.
At the outset, I'd like to thank Dr. Mali, being at the helm of affair, our team leader, for creating a beautiful place which is a Gurukul for all of us in Punjab and Northern region. And thanks to Team Lupin for this wonderful academic platform in which we can share our ideas to our worthy physicians. Dr. Neeraj has made my talk very, very easy. He has elaborated how to diagnose a patient of functional dyspepsia and very beautiful giving 3 case capsules in which there is a different scene: functional dyspepsia with EPS, functional dyspepsia with GARD, and functional dyspepsia with generalized anxiety disorder. So now I'd like to take you everybody to the management of GERD, this functional dyspepsia. My slides are visible?
No, sir, not yet.
Okay. Dr. Kajanan, you can share the slide from that side also.
Okay.
Yeah. And now my slides are visible?
No, not
No,
yet,
sir.
Pradeep.
Okay.
I think Nidhi or
Sir,
Kushi, you can assist
click
Dr.
on the
Rajiv.
share button.
Perfect. Just
Yes, now select the entire screen.
okay.
Below side, your screen preview will be there. Click on that preview.
It's not coming.
Okay, when you click on the entire screen, what option in front of you?
It is entire screen, and the screen is now, the button is on, but I'm not able to share.
Yes, sir. You need to click on the your screen preview. Below side, your screen preview is there.
Okay, just
So Rajiv, I believe you need to open your presentation and then share screen button.
okay. Okay,
First you open the presentation.
just a minute, sir. So now my presentation is open. Yes.
And now in the same this Zoom, we need to press share screen.
Yes, sir. Rajiv sir has joined from the web browser.
Okay,
So
okay,
in both of you, option will be different.
Okay.
Yeah.
Okay.
Dr. Gajanan, can you
Yes,
share the
in
screen?
that case, yes, I am sharing.
Yeah.
Okay.
Okay.
Are the slides visible?
Yes.
Yes, sir. It's visible.
Okay. Just a moment.
Yes. Yes. Dr. Mali sir, are the slides are visible?
Absolutely, Rajiv. Very
Perfect.
nicely seen. So you can
Perfect. Perfect.
start with the presentation.
So good evening, everyone. Dr. Gazanan, you have to shift the slides because control is with you. Yeah. The objectives of my talk will be to discuss management approach to functional dyspepsia, what are the available treatment options, when to add prokinetics, how to choose right prokinetic drug, and role of ecoshiamide in this particular condition. And I'll be discussing same 3 case capsules which we have diagnosed in the previous talk. Next, please. So in this talk, I'll be discussing the management guidelines of functional dyspepsia. One is Japanese guidelines, American guidelines, and Indian guidelines we'll be discussing. Next. So first of all, coming to this management algorithm by Japanese Society, as we discussed by Dr. Neeraj, once a patient of functional dyspepsia, we're contemplating if we are thinking that this patient may be having some organic disease, then there is a need of endoscopy. If on endoscopy it is normal, or if there is features of H. pylori, we can take the H. pylori biopsy, RUT. If it is positive, we can treat. And once we have treated that patient, if there is a recurrence of symptoms, or even after 1 month, patient is not responding, then probably we are dealing with the functional dyspepsia. On the other hand, if the young patient is there in which there is no indication of endoscopy biopsy, but we feel, because India being high prevalent area for H. pylori, if we feel that patient may be having H. pylori, but endoscopy is not indicated, in those patients we can do stool antigen. If it is positive, we have to treat this patient with standard treatment of H. pylori, and we have to see the symptoms. If this was a case of H. pylori related functional dyspepsia, patient will improve. But if patient doesn't improve, it means again we are dealing with functional dyspepsia. Next. So coming to these American guidelines. So now we have one patient of functional dyspepsia. As we are discussing since last 20-30 minutes, that there are 2 subgroups. One is EPS type, when there is postprandial distress syndrome, patients having blotting, early satiety, and gastric distension. On the other hand, there is epigastric pain as well as discomfort. So we believe that these are the 2 separate subgroups theoretically in which the plan will be different. In EPS, we can start with anti-secretic agents like PPI. If patient doesn't respond, we can go to second line therapy. We can add prokinetic or any other drugs. On the other hand, as per guidelines, in the patients of postprandial distress syndrome, we can directly start with prokinetic. So theoretically, it seems to be very simple. Next, please. But in real practice, what is happening, we are not seeing those patients in which they come with typically PDS or EPS. Because the data says that 1/3 patient they present with postprandial distress syndrome, 1/3 they present with EPS symptoms, 1/3 can be combination of both PDS as well as EPS. But whether this is end of story, no, because the patient is coming as a whole for these features. So there can be overlap with GERD. There can be functional dyspepsia with GERD overlap. Patient may be having underlying IBS, but we are just thinking that because he has symptoms in the upper abdomen, so it can be functional dyspepsia with IBS overlap. We have to be very careful. The patient can be having functional bloating, or patient can be overlapping with functional constipation. So this is a real story which see in the routine patients. Next, please. So what are the modalities available for functional dyspepsia? If patient is positive for H. pylori, we can give H. pylori eradication therapy. Then there is an anti-secretory therapy like PPI, but at present lately we have PCABs, but there is no role of PCAB at present in functional dyspepsia. Then of course the big armamentarium is prokinetics, which we'll be discussing. And the patients who will not respond to prokinetics, then there is a need to start TCA, tricyclic antidepressants, SSRIs and SNRIs. Next, please. So in functional dyspepsia, when to add prokinetic? Because whenever the patient is having PPI is effective in epigastric pain syndrome, but there is no data of PCAP in functional dyspepsia. But there is a low response to proton pump inhibitors in postprandial distress syndromes. So there we can add prokinetics. They tend to improve symptom of fullness as well as postprandial nausea. Next. So this is a consensus. These are the drugs available for postprandial distress syndrome. One is anti-acid suppressing drugs. Second is a group of prokinetics. Then there is a neuromodulators and psychotherapy. So today we'll be discussing the prokinetics used, which can be used for functional dyspepsia. Next. And many prokinetics are available, but practically we see that the drugs which are efficacious, which are recommended and which are safe will be delving into. So the prokinetics has their features. So we are categorizing three main drugs used in clinical practice. One is ecosamide, second is etopride, and third is levosulpride. When you talk about first effect, which is a fundal relaxation effect that due to gastric accommodation, so ecosamide scores over all other drugs. It has strong fundal relaxation effect. Then there's etopride. It is very good molecule, but the fundal relaxation effect is very, very minimal. And levosulpride is again minimal or no effect on fundal relaxations. But when you talk about gastric emptying, so the improvement with ecosamide is moderate, but with etopride and levosulpride, this effect is very, very profound. Coming to safety and tolerability, ecosamide as well as etopride, they are very, very well tolerated drugs. But levosulpride, very good prokinetic, but have many neurological adverse effects. So in this case, when you talk about ecosamide versus etoprides, so because ecosamide increases the gastric accommodation, so the patients in which there is early satiety and fullness after meals, immediately after meals, then the role of ecosamide is excellent in this profile of patients. Next. So coming to ecosamide, next please. So ecosamide has been originally developed and approved in Japan in 2013. It is world's first drug approved for functional dyspepsia. The long-term phase 3 trials completed in European as well as in Japanese and US trials are available. No clinical significant safety concerns or cardiovascular ill effects on short and long-term use of ecosamide are there. Next. Next. So coming to the mechanism of action, why this drug is very effective and very, very safe? Because it is a novel gastroprokinetic drug with the dual action specifically on gastric synaptic acetylcholine. It enhances the acetylcholine release from enteric neurons. It reduces the acetylcholine breakdown due to inhibition of synaptic acetylcholine esterase activity. Next. 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 So with this, the more acetylcholine for more time, it results in enhanced gastric accommodation and enhanced gastric emptying. Next. So coming to the pharmacokinetics, after single dose administration of ecosamide, the T half-life is more than 13 hours. It is metabolized to D-isopropyl by CYP cytochromes. 93% it is excreted in the feces, only 7% through kidney into the urine. So there is a low potential for a drug interaction with the other confounding drugs. Next. So this is a very beautiful study, initial study, how ecosamide increases the gastric accommodation reflex. This was a study done, it was double-blind, ultrasound-guided study. Gastric accommodation reflex as well as gastric emptying was studied. There was significant increase in gastric accommodation, that is 22% versus 5% versus placebo after ingestion of 400 ml of liquid meal. So there was significant increase in gastric emptying. Next. So same as discussed with Dr. Neeraj, the gastric scintigraphy study pre and post after 2 weeks of ecosamide therapy that shows there is an improved gastric accommodation and gastric emptying as compared to placebo. Next. So coming to few, there are n number of studies, few studies. The first study is long-term safety and efficacy of ecoschamide in functional dyspepsia, especially in postprandial distress syndrome, results from European phase 3 open label safety trial. Next. So this was long-term safety and efficacy trial for ecoschamide. Number was more than 200. It was a European trial in which 100 milligram of ecoschamide was given 3 times a day for a year. Next. So in all these studies, 4 evaluation score they were used. One was postprandial distress symptom score, quality of life score, work productivity and activity impairment scores, and overall treatment efficacy scores. So clinical usable is the Likert score. In some studies, they were 5 point. In other study, they were 8 point Likert score, in which they have taken the features of early satiety, postprandial fullness, bloating, epigastric pain, burning, nausea, belching, and heartburns. Next. So in this case, what they found, there was moderate to strong improvement with ecoschamide. Starting from week 1, it was 13%, then it was 40% at 12 week, and more than 70% week 52. Next. So to conclude, this study shows that 80% of patients in this study took ecoschamide for more than 50 weeks, that is around more than 300 days. There were moderate to strong improvement, increased from 13 to 70% 52 weeks. The long-term safety of ecoschamide was very good. Only 9% patient reported at least one treatment-related emergency adverse events. Next, please. Next. Yeah. So this was again phase 3 Japanese trial. Next. So this was the aim and objective was it was multi-central, open label, single arm, long-term study in patients of functional dyspepsia. They were given ecoschamide 100 milligram 3 times a day for 48 weeks from 32 centers in Japan, and the aim was to investigate the efficacy and safety of ecoschamide. Next. So in this case, as in the previous study, what they found, the overall treatment efficacy improvement was 26% week 1 and 61% at week 8. And this effect was persisting long term. Next. So in this study, what they found, the functional dyspepsia symptoms started to improve from an early stage, that is week 1, and improvement effect was maintained even after a dose interruption. And the incident rate of adverse reaction was only 11%. They were mild. Next. So after there are multiple RCTs, there was need to have real-world efficacy and tolerability of ecoschamide. Next. So this was a trial, a study, real-time study from India. So this was real-world efficacy and tolerability of ecoschamide in relieving meal-related symptoms of functional dyspepsia. Next, please. The objective was to evaluate the efficacy as well as safety of this drug. So this drug was done in India. It enrolled, next, 63 gastroenterology clinics across India, in which more than 300 functional dyspepsia patients who were having meal-related symptoms, and it was involving all 4 zones of India. Male-female ratio was 3:2, and 40 years, more than 40 years patient were more than 60%. Next. Symptomatology baseline was more than 70% they were having postprandial fullness, upper abdominal bloating, and 50% they were having early satiety. 1/3 patient they were having in addition epigastric pain, burning, few were having constipation and diarrhea. Next. So the result was, next. So there was complete, next please. There was complete or significant improvement from postprandial fullness, upper abdominal bloating, and early satiety was around 79%, 74 and 77% respectively. This study suggests the use of ecoshimide was associated with improvement of meal-related functional dyspepsia with a very good safety profile. Next. So this was very good meta-analysis of functional dyspepsia with ecoshimide. Next. So in this case, what they found that the overall this drug was very efficacious and favorable safety profile was also there. Next. The ecoshimide improved the symptoms of patients with postprandial distress syndrome. It shows significantly beneficial effect on elimination of individual function dyspepsia symptoms compared with placebo, and adverse effects were not significantly different between ecoshimide as well as placebo groups. Next. So now after these studies, we are coming to all these 3 cases which were discussed in previous presentation. Next. The first patient was 57-year-old female, functional dyspepsia. She was having combination of EPS as well as PDS with chronic non-atrophic gastritis with H. pylori infections. Next. So what pharmacological management should be preferred in such case? So in this case, patient is H. pylori positive. So we believe that she is having dyspepsia because of H. pylori. Next. So what we did, we treated her with H. pylori therapy. Triple therapy was given, omeprazole, amoxicillin as well as clarithromycin for 14 days with lifestyle modification. Next. There was only partial response to treatment. Next. So what can be done? After treatment of H. pylori, she is not responding. So what should be the other options if symptom persists after H. pylori eradication therapy? Next. So in this case, following H. pylori eradication, patient started on ecoshimide, 100 mg 3 times a day. At 4 weeks, patient reporting significant improvement in her symptoms of bloating, discomfort, nausea, and vomiting after meals. She was advised to continue ecoshimide 3 times a day before meals with on-demand PPI and followed after 1 month, but she remained absolutely fine. Next. Coming to second case, this was 35-year gentleman male, functional dyspepsia. This patient was having postprandial distress syndrome with GRD because there was lax G junction. He was having features of reflux also, GRD overlap. Next. So in this case, already patient has taken multiple PPIs for 8 weeks. So what pharmacological management should be preferred in such cases? Double dose PPI because already patient is on PPI, or we can add PPI with prokinetic or any other therapy, and why? Next. So in this case, already patient was on PPI, but patient was not responding. So apart from lifestyle modification, we started him on esomeprazole 40 mg OD with ecoshimide 3 times a day along with antacids. And patient had complete resolution of symptoms, and patient would advise ecoshimide at least for 4 weeks again, and patient remained very well. Next. So this was the third and last case. She was 42-year-old female with functional dyspepsia, postprandial distress type, but she was having generalized anxiety disorder. Next. So what is your approach to managing these cases? Next. So in this case, patient was given initially pantoprazole with levosulpiride 25 mg 3 times a day. So after 3 days of treatment, levosulpiride was stopped due to side effects such as headache, somnolence, as well as fatigue. And she was started on ecoshimide 100 mg 3 times a day before meals for 4 weeks. And still partial resolution of symptom was there. So already we have done everything. PPI given, prokinetic, and she is not responding. Next. Because the fact in this patient is that she is having generalized anxiety disorder. So probably these are the patients where we need to start tricycling antidepressant. In this case, we did same. We started on amitriptyline 10 mg once a day nighttime, and patient had significant improvement not only in GI symptoms but also in anxiety and lack of sleep. Next. So dear friends, to summarize, the carry-home message of this talk is next. Functional dyspepsia, the therapeutic options with proven efficacy, the therapies are very, very limited. The postprandial distress syndrome, there is a low response to PPI alone. The choice of prokinetic, whether it is etopride or ecosamide, should be according to the clinical profile of the patient. Ecosamide is a novel prokinetic drug having unique mechanism of action with proven efficacy and good safety profile. Ecosamide is the world's first approved treatment for functional dyspepsia, but still we can have many patients who have refractory functional dyspepsia, and there is a need to escalate therapy, maybe with the tricyclic antidepressant, SSRIs, and SNRIs. With this, I end with my talk. Next. Thank you from the team AGI, and hand it over to Dr. Mali sir for the discussion. Thank you.
So thank you, Rajiv. I think two very wonderful presentations we had, and already a number of questions are coming up from the audience. But before we go to that, I believe we have around 10 minutes with us. So what both Dr. Neeraj and Rajiv could communicate, the few, I think, salient points I would just like to sum up in 1 minute in a case capsule form, and that is functional dyspepsia, though very common, but it has not only two subtypes, but there are multiple other presentations because of overlap with many more conditions like GRD, IBS, functional constipation, or even anxiety disorder. The pathophysiology Neeraj told is multifactorial, both central and the peripheral factors. H. pylori does have a role, and we need to test and treat. And what Dr. Rajiv could show, that PDS, which again is 1/3 or little over that in our clinical presentation, what we see in our practice, prokinetics have an important role to play. And what Rajiv could allude to beautifully, that ecosamide appears to be a very important and a safe drug in treatment. Etopride also is a good prokinetic to use. So with that, I think we'll take up the different questions. First, I think, Dr. Neeraj, there are a few physicians still wishing to ask how to clinically differentiate PS from PDS. So they said, what are the important points, although it has been discussed in the presentation, but very briefly, you can highlight the difference between EPS and PDS.
So it's a very pertinent question, sir. So patients with postprandial distress, as we have discussed, so they will be having early satiety, postprandial fullness of abdomen. On the other side, if we see irritable bowel syndrome, the classical symptom will be either loose stools or constipation, and it is usually relieved after passage of stool. So that is the main symptom in irritable bowel syndrome. So if the patient is not having any constipation associated with abdominal discomfort or loose stool associated with abdominal discomfort, then your patient doesn't have irritable bowel syndrome. So on the other hand, the dyspepsia postprandial type, the main symptoms lies in the upper abdomen. So, yes.
So what Neeraj could tell, EPS is epigastric burning, discomfort or pain. PDS is normally postprandial. There are meal-related symptoms. Postprandial fullness, bloating, or early satiety. So perfect, Neeraj. So Rajiv, there are again many queries coming on prokinetics. People want to know that if it is, even we are sure it is PDS on clinical grounds, do prokinetics suffice? Or they're asking, in some subgroup of patients of PDS, you need to add PPI upfront, number one. Two, if we start prokinetics and response is partial, what would be our line of treatment? And three, they're asking how you choose what should be your first choice of prokinetic in a given patient of PDS.
Yeah, so very pertinent questions. First, whether we can start only prokinetic or we need to add PPI. Because if we are clinically very sure that we are dealing with a case of postprandial distress syndrome, then the data and clinically we say that only prokinetic is very good. But in general, in practice, we are in the habit of starting PPI. But theoretically, we can start only with prokinetic if patients having in general features of maybe mild epigastric discomfort, maybe it is not exactly pain. So PPI can be added. Regarding which prokinetic, as you mentioned, so we have only three main prokinetic agents. We are in the habit of starting domperidone, that is a very good anti-emetic effect. Now we are having etopride versus ecoshiamide and levosulpride. So levosulpride, because of the adverse effect, should not be given in females because of galactorrhea, hyperprolactinemia, and in old age population because of drowsiness as well as drug-induced Parkinsonism. So levosulpride is practically out in these two subsets between ecoshiamide as well as etopride. So what I believe, etopride is also very good molecule. Number one, it has antiemetic effect. Number two, good gastric emptying is there. And third is it is a pan-GA action. So in diabetic gastroparesis, it is very, very effective. But ecoshiamide being unique mechanism of action is postparental distress. That if it is there, then it is very good, because if somebody is having immediately after taking meals there is a blotting, then ecoshiamide overscores etopride. Yeah.
And another question, Rajiv, people are asking, is ecoshiamide safe in both pediatric and geriatric population, or the data is available only in the adult population?
What data I could find, it is pediatric less than 12 I couldn't find, but in geriatric population it is very safe. Up to 60, 70 it is safe. Yeah, but specifically because less than 12 I couldn't find any studies.
So I also believe that I think in pediatric, diagnosing functional dyspepsia per se, because it is much less common in pediatric. So, but I think adolescents, adults, and geriatric population. So what you can tell, it's a very, very safe drug.
Perfect, sir.
Rajiv, other question is coming. What combination will you prefer as PPI with ecoshiamide? So there's a if you to add, let's say it's an EPS, PDS overlap or GRD. So is there a choice we want to use ecoshiamide, choice of PPI along with ecoshiamide?
So in this case, regarding PPI, we know that in PPI, esomeprazole and rabeprazole, they're very, very effective. So normally in practice also we use esomeprazole and rabeprazole. They are very, very effective. To add, you can add etopride versus ecoshiamide, giving which subset of patients we are dealing with.
So Rajiv, I think is perfectly right, because both these drugs have a much longer half-life compared to the other counterparts in the PPI group. So more acid suppression, so likely to have a better benefit. So question to Dr. Neeraj from the audience. In people with H. pylori positive functional dyspepsia, if we have given an eradication therapy for 2 weeks, one, they want to ask, do you check for eradication always? If you check, do you stop all therapies or you keep on some medicine in the interval when eradication has been given and you're checking for the eradication, say 2 to 4 weeks later? So what is the treatment protocol in such patients?
Regarding the treatment part for H. pylori, once we have given 2 weeks treatment for H. pylori, so we usually do not recommend testing for H. pylori. So if the symptoms have subsided, there is no need to test for eradication. But if you have a doubt that the patient has not responded very well to the treatment, then definitely we can check for H. pylori. So either it can be again a non-invasive method, we can use by breath test, urease breath test, or we can do a stool antigen. The invasive method, again, we can do rapid urease test, or we can do a histopathology by sending a specimen. So regarding the treatment part, once we have finished a 2-week course of H. pylori, then we usually put these patients on either, depending on the symptoms, because these patients still might be having symptoms of dyspepsia. So we can put these patients on prokinetics. If the patients also have some symptoms of overlap of gastroesophageal reflux, then definitely we can add PPIs.
So I think Neeraj's point is very well clear. So if there's a complete amelioration of the symptoms, you can give a trial of stopping all therapy. And if you go in meta-analysis, number needed to treat is somewhere between 8 to 12. So every 8 to 12 patients you treat, one will be the one which will have complete symptomatic relief. So you can take them off drugs. And if symptoms reappear, then depending upon the type of symptoms, we can put them on the therapy according to the symptomatic profile of that patient. So now another question to Rajiv, how and when to use extended release ecoshiamide, which is a 300 milligrams, and is extended release as efficacious as thrice daily ecoshiamide before meals?
In personal use, I have not used extended release. I'm personally using 100 milligram 3 times a day, but
Right.
because the T half is very good, it is more than 13 hours. But because the medical team can just tell how much there is a difference, but practically 3 times a day, practically we are using.
So I again fully agree with Rajiv. So ecoshiamide, we don't have an experience. We have used sustained release formulation of etopride, but we actually feel it to be inferior compared to if you give 50 milligram of etopride thrice daily, 30 minutes before meals. So I think the team can tell us, the Lupin team, but most of the gastroenterologists do believe that thrice daily is superior compared to just a single time extended release medication. So another question on ecoshiamide, Rajiv, is coming. People who have an incomplete symptom relief after initial course of therapy with ecoshiamide, what adjustments can be made either in dose or on treatment?
Personally, I believe that if our diagnosis is correct, if patient is not responding, we have to revisit our diagnosis. Because any prokinetic, maybe it is etopride or ecoshiamide, if patient is not responding, so there can be other facts. Because if ecoshiamide is not effective, it can be extended, but there can be multiple reasons. Confounding factor has to be found out, because if it is not effective, it doesn't mean that if it prolonged, because the effect of ecoshiamide started within 1 to 4 weeks. So we can extend up to 4 weeks. If it is not responding, we have to go to your diagnosis. Yeah. Or
And
we
then
have to
again,
add any other thing.
So again, the one question which also we come across routinely, people are asking, is a 2 prokinetics better than 1 if 1 is showing only a partial response?
So this is very, very relevant question, because normally in clinical practice, the patients are on PPI or PPI with domperidone. Suppose it is esomeprazole and domperidone combination. So domperidone per se is having anti-emetic effect. In that case, we can add ecoshiamide or etopride. So that makes sense. But whether we can add etopride and ecoshiamide, theoretically, yes, because ecoshiamide acts on increasing the fundal relaxations. But practically, I don't feel like that, because there is an effect on gastric emptying boats. So domperidone per se plus ecoshiamide or etopride can be added rather than 2 prokinetic like ecoshiamide as well as this etopride. Yeah.
So I think the answer, Rajiv, is very clearly said. Theoretically, maybe yes, but going by the guidelines or practice, I think still we need to stick to a single prokinetic with PPI, revisit the diagnosis, and if there's an anxiety or underlying neuropsychiatric ailment, then use some neuromodulator.
Perfect.
So there's another question. Is there a diagnostic test which can be clinically done for PDS, like drinking water test, like drinking 300 ml or 500 ml? So this is among the physician. If someone cannot tolerate, say, a 300 ml of liquid at a given point of time, this patient has PDS. Is there any sort of such test which can be of help?
So this is part of actually electrogastrography, sir. While doing an electrogastrography also, we see how much water intake patient can have without having any discomfort. So if he's able to take at least 300 ml of water, so then it means that this patient is not having postprandial distress or early satiety. But definitely this has its own limitations, because see, we are giving just water. So this patient still might be having dyspepsia after having a meal, a solid meal. So that is the main thing. So again, while doing an EGG, when we give water, we also check the readings on the electrogastrography. So how is the contraction of the stomach are coming? So whether it is tachygastria or bradygastria, so that also helps us in evaluating that patient.
So Rajiv, another question which is coming, how long ecoshiamide needs to be continued, and what are the stopping rules for ecoshiamide?
Yeah, very, very pertinent question, because in the studies we have seen that ecoshiamide was used for 48 to 52 weeks. But practically, patient normally responds within 4 to 8 weeks. If once
Right.
patient has responded, it can be given maybe another 4 weeks. Then we have to decrease it and we have to stop it. So I believe 8 to 12 weeks is the optimal duration of Ecosia that needs to be stopped. Then patient can be on on-demand PPI if it is needed.
Perfect. Neeraj, same question which you did discuss in presentation, but question is coming. Patient below 50 years, no red flags, pure functional dyspepsia, empiric therapy versus endoscopy.
As I discussed, if there is no red flag sign and the age is less than 50, so there is a role of test and treat strategy for H. pylori. If your patient is not willing for endoscopy, we can test for H. pylori using either a stool antigen or you can do a urea breath test. So with that, you can confirm your diagnosis of H. pylori. If it comes positive, because we are in a high prevalence region, so we should definitely test for H. pylori. If it comes positive, we should put our patient on H. pylori eradication treatment. If it is negative, then we can maybe empirically give PPI for, as discussed, for 6 to 8 weeks. Patient is not responding. Again, we should recommend this patient an upper GI endoscopy.
Perfect. So Neeraj is very clear. Test for H. pylori, positive, you treat. If not there, you diagnose them clinically as EPS or PDS, PDS prokinetics, EPS PPIs, overlap, a combination of the two. So I think that's how we need to go about that. So I think with that, most of the major questions which Dr. Gajanan, do you have any other questions with you? But most likely the major queries which people had raised, I think we've already taken them up.
No more questions, sir, from the audience side.
Okay. So I think then last minute, I think 30 seconds each from Rajiv, then Neeraj, then I'll, and then I think Dr. Gajanan will say the final few words to close the show. Dr. Rajiv?
Sure, sir.
Yeah. So again, dear friends, it was very good academic session on functional dyspepsia, how to diagnose and how to treat. I still believe that the efficacy of many drugs, apart from Ecosia and etoposide, is not there. We have to make our diagnosis correctly, and we have to use these drugs very judiciously. And once patient is not responding, we have to revisit our diagnosis rather than giving these medicines for indefinite period. And still we are waiting. The functional dyspepsia, still it is a mystery, just like IBS. As the diagnosis will become more clear, what is the pathophysiology, more and more drugs will come. But as for now, two prokinetics, etoposide and Ecosia, they have very good role and should be used in the patients who needs them most. That will help us, and timely stopping rules should be applied to these drugs. Yes, that's all from my side, sir.
Neeraj?
So, from my end, so main important thing is that you rule out organic causes of dyspepsia. So that is very important. First, while taking a history, look for any red flag signs. So whenever if you feel there is any red flag sign, so you should directly refer these patients for an endoscopy. So otherwise, definitely there is role of empirical PPI therapy, but we should always consider H. pylori in our diagnosis because we are in a high prevalence state. So there are multiple ways which we can test if your patient is willing for endoscopy. So that is the best way. More affirmative diagnosis, not willing, still there are methods which you can diagnose so that we can treat this disease.
So I think wonderful. So I'll say two speakers, both had a very lucid presentations, made this topic even more interesting, and what they could clarify to the audience. So it's a clinical thing. So you need to spend time with the patient. We need to subcategorize. Whenever in doubt, we should investigate. And once we are clear with the diagnosis, the appropriate line of treatment should be instituted from the very beginning. So I would say a lot of misconceptions cleared, lot of myths dispelled. So real thankful to both Neeraj and Rajiv for making all of us and the whole audience much wiser with today's presentation. Thank you, colleagues.
Thank you.
Thank you, sir.
Thank you.
Gajanan? ball is in your court.
Yes, so as we have come to end of this insightful session, I take a moment to thank everyone for making this CME a success. First of all, I would like to thank our chairperson, Dr. Nirmal Singh Malli, and our speakers, Dr. Neeraj Singla and Dr. Rajiv Goel, for sharing the expertise and insights. Your presentation and discussions have enriched our understanding of the topic functional dyspepsia, focusing on postprandial distress syndrome and the use of prokinetics, especially acosamide in this scenario. Also, I thank our audience for their active participation and engagement and posting their queries, which has made this CME an enriching experience. I hope the presentation will have a lasting impact on your clinical practice. So thanks once again, everyone. We hope to reconvene soon, continuing our pursuit of scientific excellence and advancement. Good night, everyone. Bye.
Thank you, Dr. Gaganan. Okay, sir.
Okay, bye Rajiv,
Bye, sir.
bye Neeraj, bye
Thank you, sir.
Gajanan, the whole
Thank you
team.
so much, sir. So
Lupin
from here, I'm ending
Pharmaceuticals.
this meeting.